MedCram.com.
Welcome to another MedCram bird flu update. Today we're going to talk about what's going on in Canada with this teenager that's been hospitalized. And we're going to talk a little bit about why sunlight and influenza may actually be a thing. And then I really want you to hang on because at the end, we're going to talk about a pretty incredible case that I learned about recently this week. But first, let's talk about what's going on with this teenager in British Columbia, Canada. He is from Fraser Valley, and he's the first person to have contracted the H5 virus in Canada. Now, we don't know whether or not this is an N1. It's presumably N1, but we don't know for sure. It's definitely H5. The health official is saying that this was a healthy teenager prior to this, so no underlying conditions. And these symptoms started pretty recently, November 2nd. He was tested, sent home, and then came back when symptoms got worse, and the test came back positive for H5. Initial symptoms were conjunctivitis, and they have done extensive testing in this gentleman's family. All of them are negative. The patient was not at school during the infectious period of the disease. This was like around October 30th or 31st. There's no links to the rest of the world, especially where they have right now H5N1 in Southeast Asia. This patient did not go and visit any animal farms. He was in contact with some dogs and cats and reptiles before becoming ill, but those have been tested and were negative. He's had no link to poultry farm outbreaks or cattle farms, dairy farms. Now, most of the human cases in the United States that we've seen have actually done pretty well. Almost all of those were from dairy cattle farms, and we also have some animals like cats that were drinking infected milk from cows. This is a disease, H5N1, if that's what it is, that since 1997, there's been almost 1,000 cases globally, and 50% of these resulting in death. So this is not a disease to fool around with. I wanted to review some data that we've talked about before, but I wanted to bring it up again in light of the case that we're going to bring up at the end. And what I want to show you here is the top 7 killers in 2020 in the United States. And looking back on the previous 4 or 5 years, whether we're talking about heart disease, which of course is the biggest killer, or cancer, or chronic lower respiratory diseases, or Alzheimer's disease, or diabetes, or influenza and pneumonia, or kidney disease, etc., I want you to notice that all of these diseases peak right here when the year changes, or in other words, about a week or two after the shortest day of the year. This is in every single case. They all peak at around the same time. As mentioned, that of course happens to be the shortest day of the year. It is exactly at its lowest point just a few weeks after the longest day of the year. If you noticed here, it's when these natural cause of deaths are the lowest. And of course, I would say that this is related to sunlight. But you could say that this could be related to the fact that it's cold in the wintertime, that people go indoors, and this is when the virus gets to spread around. But heart disease, not necessarily an infectious disease. Diabetes, not necessarily an infectious disease here. Alzheimer's disease, kidney disease. All of these things are happening at the same time. Let's simplify it and let's take a look here at just influenza deaths, since that's what we're talking about today is influenza. If we look at influenza or flu deaths per week in the United States, going up to 2020, which is when this graph was constructed, you will see once again that the peaks in the United States, in countries in the Northern Hemisphere, they all peak maybe 1 or 2 weeks after the shortest day of the year. And we see this every single year. So you may be asking yourself, well, I wonder what happens in the Southern Hemisphere. For instance, what happens in Australia? Let's take a look. Here is a paper that was published, available at Science Direct. Influenza-associated mortality in Australia, 2010 through 2019. High modeled estimates in 2017. So what we have here is the H1N1. We also have the H3N2. And then, of course, we have total influenza. So again, we're looking at the same sort of graph. There's nothing here where the year changes like there was in the Northern Hemisphere, because now the shortest day of the year is actually shortly after the longest day of the year in the Northern Hemisphere, which is exactly here a few weeks after June 21st. And this is exactly where we are seeing these spikes. It is right surrounding the shortest day of the year. So you may say in Australia, this has to do with the fact, again, that it's cold and that people bundle up and they go inside. But in fact, July is the coldest month of the year in Australia. The average highs in July in Australia is like 63 degrees Fahrenheit, which is pretty mild. It really doesn't get that cold in Australia. It does get very warm, but according to the data, it doesn't. So this may not be actually a very good explanation. In fact, it sort of bolsters the idea that this has to do with sunlight. In fact, there was a paper that was published around that same time in July of 2020 in the Harvard Kennedy School and looked at CDC data for influenza in the United States, actually looked at it in the United States and county by county in New York for another analysis. And they looked at something called solar radiation data from the National Solar Radiation Database. So they're not looking at just latitude, they're looking to see how much sunlight does any particular area get. That could be varied, not just on latitude, but also on weather patterns, on altitude, on cloud cover. There are certain areas of the country that get more sunlight. And here is the spoiler alert quote from the study. We find that sunlight strongly protects against getting influenza. Let's look at the actual study here. This is the abstract, and they said that we find that sunlight strongly protects against getting influenza. Why is that? When we look at our relationship, the sunlight is going to be the least around that late December period. So they're going to say, well, how is it that we know that it's sunlight that's doing it? For those of you who may not remember, in 2009, there was the H5N1 epidemic in the United States. And this actually happened much earlier in the year at a time when there was supposed to be more sunlight, but there actually wasn't that much sunlight, and there was actually variability. Let's talk about that here. This is from the paper. They said here, normally, flu season is in the wintertime, when both the average and the variance of sunlight levels are low. However, the experience with the H5N1 flu epidemic in 2009 was dramatically different. The epidemic peaked much earlier, in late summer and early fall. Those few months also had lower than average sunlight. This is sufficient concurrent variation in both sunlight and flu to study this relationship. So again, this is in the middle of the summer, so you cannot say that the reason why you have these spikes is because it's cold and people bundle up, and that's what perpetuates the virus. Here we're seeing that this is the warm summer months of July. There just wasn't as much sunlight during that period of time. So this actually decouples this idea of sun, wintertime, and warmth. They go on to say the studies on the 2009 H5N1 outbreak do not substantially investigate the relationship between it and sunlight. They're talking about studies prior to this. However, this paper, because of this variation, is the first to investigate the relationship between the 2009 H5N1 outbreak and sunlight, and the first to perform its analysis at 2 levels of aggregation across the United States and also counties in New York. We'll focus on the United States in our analysis here today, and they said that the results at the 2 levels were consistent. So here's the data, and you can see the 2009 are all these red circles. Can you see how there's a much wider scattering, and it allows us to actually figure out where the best fitting line is? All of the other years like 2010, 2011, 2012, 2013, 2014, 2015, 16, all of these are sort of huddled in this area here. But when you add in 2009, you can clearly see this relationship, which states that as you reduce sunlight levels, what do you typically see here? You see an increase in the mean flu index. So that's really important to understand because sunlight, it seems, is doing something to the human body, probably well past vitamin D, to improve either the incidence of influenza, the mortality of influenza, or it does something to mitigate the effect of influenza on the human body. So let's take a look why that might be. The majority of sunlight is made up of photons in the near infrared spectrum. So if we look at some of these studies that have been done, this time with COVID, showed that there is some mitigation of this high inflammatory response. So the name of this paper that was published back in 2021 is Infrared Light Therapy Relieves Toll-like Receptor 4-Dependent Hyperinflammation of the type induced by COVID-19. Let me just say that this type of inflammation is also induced by influenza. What do we see here? So these very inflammatory cytokines like IL-6, IL-8, tumor necrosis factor alpha, and then the humoral or antibody-inducing interferons like interferon alpha and interferon beta. Notice what happens when we go from the control in all of these to LED lights that give off infrared or incandescents that give off, of course, infrared light. Notice that there is a significant drop-off. So what are we saying here? We're saying that infrared light, at least in these models, shows a dramatic drop-off in the very cytokines that we know causes mischief in influenza and COVID-19. But what about the ability of the immune system? Here, when we're looking at a different type of interferon gamma, there is actually an increase over a period of time being in the sunlight. And this is the type of interferon that's actually involved with cell-mediated immunity, the type of cells that actually get rid of infected cells with the virus. A benefit, again, looking at UVB coming from sunlight. And we know that sunlight is a mix between ultraviolet B radiation, ultraviolet A radiation, and infrared light, as well as visible light. Getting back to the issue in terms of infrared light, there was this randomized controlled trial that we've talked about before from Brazil, where they actually gave 940 nanometer light at just 15 minutes a day, plus conventional therapy, to 30 patients that were inclusive of those 50 to 80 years of age admitted to the floor with COVID-19 not requiring intubation. What happened in these situations? Those that got near-infrared light had improvement in their oxygen saturation that was faster than the control group. They were able to take deeper and stronger breaths than the control group. Their respiratory rate and heart rates improved faster. Their immune systems were more robust. And they were discharged from the hospital a full 4 days earlier when they got just 15 minutes a day of 940 nanometer light. When I saw this, I knew that I was going to have my patients with COVID-19 coming into the hospital be treated with sunlight. And I had my opportunity just about a year ago when I had a patient that was admitted to the floor that had been there for 2 days, getting the standard treatment of solumedrol and azithromycin. And despite the 2 days he was treated with that, he went from 4 liters nasal cannula to 10 liters oximizer, 10 liters oximizer. And then finally, on the day that I saw him, I was asked to see him because he was threatening to be intubated because of the increased oxygen requirements and work of breathing. He was on 35 liters of oxygen, 100% high flow. It was at that point that we convinced him to get outside into the light. He didn't want to do it at first, but we were very convincing to do that. And we just did it for 20 to 30 minutes each day, full sunlight. And what happened? Within 5 days, this patient was discharged from the hospital without oxygen. You can see how quickly that oxygen content went down. So that's a story that I've shared before. And this is a picture of the gentleman. Did very well getting outside and getting sunlight. But I wanted to mention to you a recent phone conversation that I had with somebody that left a message in the front office at medcram.com. This is someone that's already on Instagram. Amy Honmeyer contacted me, and it was just an amazing conversation that we had about her son, who is a minor. He's 15 years old, and she would not mind me telling you about his case. She's actually talked about his case on her own Instagram account, and I just want to tell you a little bit about what she showed me. It's really quite remarkable. I bring up this case study not because I believe that it proves that sunlight is beneficial in people with lung diseases, but rather it demonstrates how potentially easy it can be to get people outside and what potentially are the benefits. I believe that the evidence that I've just showed you, that epidemiological data, the randomized controlled data, and what happens in terms of the cycling epidemiologically every year in both the northern hemisphere and the southern hemisphere is strongly suggestive that sunlight is beneficial in influenza and other respiratory diseases, notwithstanding the Harvard study, which of course is very, very persuasive. Let's talk about this case study. So this is a 15-year-old Caucasian male. Back in September of 2023, he was diagnosed with a B-cell acute lymphoblastic leukemia. It's a pretty aggressive blood tumor. He was started on chemotherapy at that time. But in May of 2024, this year, when he was getting some pretty aggressive chemotherapy, he had to stop due to an illness. He had a cough, runny nose, and he was found to have something called a neutropenic fever. This is when the major fighting component of your white blood cells are at their lowest, likely because of the chemotherapy, and developed a fever. Usually in this situation, you simply admit the patient to the hospital, give them antibiotics, they usually get better, and it's not a problem. They go back to the chemotherapy that they should be getting. However, in this case, it did not end up that way. This is admitted again on June 1st. By June 8th, he had a CT scan, which showed a pretty involved pneumonia, not only in the sinuses, but importantly in the left lung. The lingula is a sublobe, if you will, of the upper lobe on the left side. And so his left lung was involved with some sort of pneumonia. Now, it was just a matter of maybe a few days, a week or so later, that they were able to get the culture results back that showed him infected with a mucor fungus. This is a horrible type of infection. You can look up mucor. It is a flesh-eating fungus. It will invade and go across fascial planes and invade blood vessels. The treatment for this is very powerful antifungal medications like amphotericin B and posaconazole. And despite this, oftentimes surgery is necessary to cut out the mucor. And so the patient was started immediately on amphotericin B and posaconazole. Bronchoscopies were done to see what was going on. The patient actually had this fungus ball and a significant effusion requiring a chest tube. Despite the fact that the patient was on very powerful antibiotics and in the hospital at this time getting all the care that they could get, the CT scan on the 28th of June showed that there was hypoenhancement, which basically means that there was deadening tissue. So the lung was basically being eaten from the inside out by this fungus. At that point, they placed larger chest tube sizes at the end of June, and the patient was transferred to the adult side of the hospital where they had a thoracic surgeon that was able to consider actually doing surgery on that left lung. After they looked at it, the patient actually had a pretty significant surgery where they actually removed the entire left lung. The patient had a feeding tube placement and an Allred flap. This is basically where they leave a pretty sizable flap of skin open to the thoracic cage so they can go in and make sure that the infection clears itself so that they're not trapped in there. Patient was transferred to the SICU on July 1st. I would note, by the way, this is the first day that new residents come into the hospital. On July 2nd, her son was extubated, brought back to the OR for dressing changes. And about a week later, they thought they might have been in the clear, but they started noticing the white blood cell count going up. At that point, antibiotics were broadened. There was new nodules found on the July 8th CT scan, which was not good. Of course, the patient does not have any lung on the left. He only has a right lung. Cultures were sent. The Allred flap was closed, and posaconazole was stopped because of LFTs increasing, but then restarted again back on the 13th, so didn't actually lose some time. This is when things started to go downhill. On the 14th and the 16th, there were some ongoing fevers. This was despite the fact that the patient was on very strong antifungal therapy. And then finally, on the 16th of July, patients started having worsening oxygenation. They had to increase the amount of oxygen they were giving him, even having to go to BiPAP on the 15th. He had ongoing fevers. A CT scan was performed. Let me show you that CT scan. This is what is left of the lung after it was taken out. The left lung, remember that the left is on this side and the right lung is on this side. What I've done here is I've actually taken the actual images of this CT scan. If you look at the lungs kind of like this, and of course there's no left lung, and I've taken a cut through this area here, through this area, and through this area. Okay, so we have a top slice, we have a middle slice, and we have a bottom slice. So this is the top slice here, and what I want you to notice is that the right lung here is very involved with white inflammation. Black is air. This is what it should be looking like. You can see that this area here is all involved with inflammation. Again, here a little bit further down, same sort of situation. And here in the bottom, there is a little bit more aeration, which is good, but this area right here is fluid. And again, this shows that the right lung is involved. What happened? When the team saw this CT scan, they thought that this was likely invasive mucor. Of course, there's no surgical options. You can't take this lung out. He's not going to have any more lungs. Well, you could do heart-lung machine, but as an ECMO candidate, this has to be a bridge to something. And there was no bridge because unless he was well enough to get chemotherapy, the ALL was going to end his life. And so they came to the inescapable understanding that there was nothing further to offer the patient. Obviously, they were very upset. The physicians were very upset. They don't like to lose people. The oncologist, the surgeon, the intensivist that were all taking care of them, they actually had a family conference. They discussed some options. Could they do a bronchoscopy? Could they do a thoracentesis on the left to try to remove some of this fluid to allow more space for this to inflate? All of this were issues that were discussed with the parents. And after a long discussion that I was not a part of, I was not one of the treating physicians. I'm getting this from Amy, the mom. And in her own words, they came to the understanding that her son needed to be intubated. If he was going to get on that ventilator, there was very little hope that he would be able to get off that ventilator. And so he was made something called DNR, or do not resuscitate, with the focus on maintaining the IV therapies that he was already getting, but not escalating care. Imagine trying to communicate this decision as parents to your own child who is fully awake and alert and can understand this. And you can understand how this was really, really difficult. When this sort of thing happens, I can tell you as a physician and the nurses that surround me and that work on patients, when there comes to a point where we can't do anything more medically, obviously we're going to do everything we possibly can for the patient to make sure that they are comfortable, that they're not suffering, that we do whatever it is that they want to do. And that's exactly what they did. They came to this boy who was going through just a tremendous time here in the hospital. He'd already been in the hospital now for a good 6 weeks. And they asked him, what did he want to do? What was it that he really wanted to do? And here's the key. He expressed a desire to go outside on 7/16. That was the day that all this bad news came down. So I want to tell you something that they were doing, actually, up to this point every once in a while. And it's this device called a Firefly, which actually gives off different amounts of light. They have been using it up to this point with mixed results, obviously, right? So he wasn't better. And so what's about to happen is that the staff is going to do everything in their power to get this guy outside. And in addition, the family, since there's nothing else they can do, they're going to bring this back and actually start using it. Let me show you what happened. The next day on 7/17, patient goes outside for a good 4 hours. He still has a fever. White blood cell count is 27.5, which is really elevated. And the neutrophils, which is a component of this white blood cell count, is 22.6. Next day, on the 18th, goes back outside for a good 4.5 hours, and they use this device called the Firefly, which I just showed you, just for 5 minutes, 3 times a day. By this point, the fever is gone. The white blood cell count, which had been elevated for days, weeks, perhaps, is now down to 18.0, neutrophils down to 13.7. And during this time, by the way, the oxygen requirements are starting to reduce. At the beginning here, the patient is on BiPAP. That's basically non-invasive ventilation. It's as if they're on a ventilator, but there's no tube going down the throat. It's just a mask. We get to 7/19, only spent about an hour outside. Firefly again, fever's gone, white blood cell count down to 7.9, neutrophils down to 4.8. I should point out to you that when the staff talked to this patient back on the 16th, he asked how many days did he have to live, and they told him about 2 days. You can see here that we're already past the 2 days and he's improving. And the staff knew it. They thought, well, maybe they were wrong. Maybe something else had changed. Nothing had changed in terms of the treatments that this patient was getting, except for the fact that he was now getting outside. And it wasn't easy to do. They had to keep switching out oxygen tanks. They had to make sure that the BiPAP machine was working. They had to make sure that he was being monitored appropriately. Although they were willing, because he was DNR, to take him outside, that might not happen to people who are full code because you have to be able to do chest compressions. And if there is a code outside, it's obviously going to be more difficult because you have to get the crash cart out there. On the 20th, outside again for another 3.5 hours, Firefly, 5 minutes, 3 times a day, fever's still gone. By this point, the physicians taking care of him start to ask, if he's getting better, let's get a CT scan to see if that's actually happening. And if it is, maybe we can get him on chemotherapy and get him ahead in terms of the ALL. I want to show you again. These are all CT scans that were taken on 7/16. So what happened on 7/16? This was the CT scan. This is the bad news day. This is the 2 days left to live. They did a CT scan on the 22nd after he was out in the sun, and they did the Firefly. I want to show you the CT scan results after just 5 days of being in the sun. And these are exactly at the same cuts that we saw. What do you notice here? What you see is that the inflammation is gone. the inflammation has dramatically dropped off. And this is exactly what we had shown with the studies before, that infrared light gates the toll-like receptor 4, shuts it down, and you have a reduction in the inflammatory cytokines that are going on in the body. This is an October scan. So this was just done literally a month ago. His lungs on this side, obviously his lung on the left is completely gone. That's not coming back. But if you notice here, there's not a single sign of the fungus anywhere after this patient went outside and used that light device. If you are interested to learn more about this story and hear more details, in the words of Amy herself, I would highly recommend that you either go to our Twitter account. This is my Twitter account that you can find it at. We have a space where we actually did a recording. Or what I will do is I will post a link to a MP3 file that actually goes through that space, and you can see it actually in the description below. So this takes me back to our original case. Here we also have a teenager who's in critical condition. He's in the hospital, and he's in British Columbia. And I just looked up the weather report up there, and unfortunately it's cloudy and rainy. But if it were sunny, I would highly recommend, and if it does get sunny and the weather changes, I would highly recommend that he get outside for just 20 to 30 minutes. That's all that was necessary in that randomized controlled trial that they did in Brazil on the COVID patients there. I think that given the fact that this patient actually has a type of influenza, it's still going to be beneficial based on the data that we see with the seasonal data, the Harvard study that said that sunlight is strongly protective against influenza, and all that we know in terms of infrared light. Many MedCram listeners will know that we've also talked extensively about hydrotherapy and the fact that raising the body temperature can improve interferon secretion, which is actually very important in taking care of influenza. There's also a lot of history in terms of what we used to do in this country and other countries in terms of treating the pandemic that we saw back in 1918. A number of sanitariums used hydrotherapy and sunlight and had 1/6 of the case fatality rate that they saw in the Army hospitals. I'm really hoping that we see more research looking at these potential interventions like sunlight, hydrotherapy in these very large pandemics. Why? Because sunlight and hydrotherapy is not supply chain dependent. This is something that can be easily available even in a major pandemic where a supply chain may be disrupted. And I, for one, would really like to see more funding for this at the government level. And the reason is simple, because we're not going to see a lot of companies putting a lot of money into this type of research because it's not really a proprietary intervention. Sunlight is basically free. It doesn't require a supply chain. Hopefully you're in an area of the planet where you can get an abundance of sunshine. But even if you can't, there are potentially other things that we can do like lights and hydrotherapy that might be beneficial. Hydrotherapy itself, or elevating the body temperature, or at least not preventing a fever from occurring, is also beneficial and doesn't really require a supply chain either. So I hope that this video has been instructive. Subscribe, turn on notifications, give us a comment below, and look at the description for the studies and also that link for Amy's testimony in terms of her son and what's going on right now in terms of his ALL. Thanks for joining us.